Next, I call upon Dr. Muralidhar for his talk on wobbly eyes, the ophthalmologist's approach to nystagmus. Now, Dr. Muralidhar is coming all the way from Coimbatore. He's working in Eye Foundation and is an experienced ophthalmic surgeon, pediatric ophthalmologist, glaucoma, and neuroophthalmology. And thank you, Dr. Murali, for coming all the way from Coimbatore to enlighten us on this topic. Over to Dr. Murali.
Thank you, madam. Thank you very much, and thank you, Lakshmi and the scientific committee for having invited me for this wonderful talk. It's a pleasure to be with you all. So I'll talk about the ophthalmologist's approach to nystagmus, and so because this was for the general ophthalmologist as well. So we all know the definition of nystagmus. I would just reiterate that I'll be showing some videos of pseudo-nystagmus. So it's a regular rhythmic to and fro oscillatory movements. Usually it's involuntary. And if you have facilities for ocular recording, the defoveating, the movement that sweeps the eye off the fovea, it's a slow movement and not a fast movement. I'll show some videos why I have specifically chosen these 3 points. So you need to take the history. Usually they say that the distinction is very important because congenital may not require any further evaluation, whereas acquired nystagmus requires a neurological workup. So usually acquired will have oscillopsia, whereas congenital will not have. There are some exceptions to this, but this is a general rule that if the patient says that he or she has oscillopsia, it's possibly an acquired nystagmus, and of course the associated clinical features. So this is the flow chart of nystagmus, which I have adapted and modified from mrcoff.com. So the nystagmus that primarily concerns us is that which is manifest in primary position, and Kogan divided into motor and sensory nystagmus. This classification may not be very relevant now, but clinically it's very useful. So vision is less than 618, you have to look for a cause for the vision loss. Vision is better than 618, then you have to look for means to correct the head posture, if any. So if it is evoked only on eye movement, you have these. I'll show the videos, and that which is evident only on cover or is accentuated on cover. So this is the key thing which will occupy most of my talk. So this is a child who has nystagmus and poor vision, that is his father holding him. So obviously it's a patient with oculocutaneous albinism. It may not be as obvious as this. Sometimes it may be evident only by iris hypopigmentation or iris transillumination defects. So this we need to look for any obvious cause that could account for the poor vision of this child, especially if the nystagmus is pendular. So this was a older patient. You can see the cataract here. So this again accounts for the vision loss, and this is a sensory nystagmus. Again, this distinction is technically not correct, but clinically it's very useful to divide it into a motor nystagmus and a sensory nystagmus. So at some point, for some patients, they will have normal fundus. For them, ERG is very, very useful. So this was an adult patient, this was a child, and vision was only 636. And you ask for history of consanguinity, which is very rampant in this part of the world, and of course history of night blindness or day blindness. So that helps you identify these sensory causes for nystagmus. So this was a very interesting patient. The neurologist had referred it to me. So he has head nodding with congenital nystagmus. Sorry, congenital is no longer an appropriate term. So infantile nystagmus. So infantile nystagmus syndrome can also have head nodding, but in this patient the head nodding disappeared in 2 to 3 years. So this was a patient with spasmus nutans. In spasmus nutans, the nystagmus may not be as obvious as in this. It's called ocular shimmer, can also be asymmetric. You need to do a neuroimaging to rule out lesions of the optic nerve and chiasm, and in this patient everything was normal and it remitted spontaneously, so we didn't have to do anything. So this was a patient who presented with oscillopsia. So note the nystagmus here. So the important feature in this kind of nystagmus is the patient will not be able to sustain it for more than 30 seconds. So they present with, some of them use it as a trick, some of them are scared of it, but this is a patient with voluntary nystagmus, so they will never be able to sustain it for more than 30 seconds, requires no further workup. So this was a patient with bitemporal hemianopia and with acquired oscillopsia. So she has an acquired seesaw nystagmus. So there are congenital variants as well, but this is an acquired seesaw nystagmus because by history we knew that this was an acquired seesaw nystagmus. On visual fields she had bitemporal hemianopia and she had a cellar mass that caused this. So cellar and paracellar masses, whatever compresses and causes chiasmal dysfunction can cause a seesaw nystagmus. So this was a very, very interesting eye movement. Was referred to me as dissociated torsional deviation, but actually this was acquired. The patient had been seen by a neurologist earlier, suspected brainstem infarction. So note this movement, which is initiated by a saccade. We had also reported this in IGO. So this is a patient with dorsipulsion. So they will present with all kinds of vague complaints like the room tilted to one side. Sometimes they are thought of as psychiatric. They usually have a dissociated anesthesia, only pain and temperature on one side of the face and other side of the body. So this is a typical patient with a Wallenberg syndrome, which is a infarction of the dorsolateral medulla, generally caused by, so this is the cerebellum, and so this is the infarction in the dorsolateral medulla. So this is a typical patient with So this is a typical patient with Wallenberg syndrome. I hope you are able to see my arrow. This is the infarction in the dorsolateral medulla. So this patient presented with a history of double vision, history of headache. You see the disc edema here, you notice the lag ophthalmos here, and patient had corneal hypoesthesia also. What I wanted to show here was a Brunn's nystagmus, very, very typical. On the side of the lesion, the nystagmus is large amplitude and low frequency. When the patient looks away from the side of the lesion, the frequency of nystagmus increases, the amplitude reduces. So the very, very typical patient with Brunn's nystagmus, almost a textbook picture of a CP angle tumor. So this was the CP angle tumor, and these are the dilated ventricles causing an obstructive hydrocephalus. So this was another patient who survived a road traffic accident. Notice the nystagmus in the abducting eye, and the adduction is restricted, improves slightly on convergence. So it is actually a pseudo nystagmus. It is not a regular or rhythmic eye movement. So it's a patient with a left internuclear ophthalmoplegia, and you have to tell the radiologist because the lesion area is very small. So there was a small lesion in the medial longitudinal fasciculus on diffusion weighted imaging. So unless you tell the radiologist, it is like searching for a needle in a haystack. So you have to tell where exactly you are looking for the movement. So this was the reason why I said the defoveating eye movement. The movement that sweeps the eye off the fovea is a slow movement in nystagmus. So this is not a nystagmus. So by and large, if you notice, the movement is in the vertical plane. There are intruding horizontal saccades also. So this is a patient with an opsoclonus. In a nystagmus, the defoveating, the movement that sweeps the eye off the fovea is a slow movement. In this patient, it's a fast eye movement. So mainly vertical, occasional oblique and horizontal. So very typical opsoclonus. Oncology workup was negative, so was diagnosed as a opsoclonus myoclonus syndrome by the neurologist who had referred it to me. Who was started on baclofen steroids, and patient improved actually. So this is another very typical eye movement which you need to recognize. This is not a nystagmus. This is actually even though it's called as convergence retraction nystagmus in Parinod's dorsal midbrain syndrome. So this patient also had papilledema. You notice the dilated third ventricle here, and this was the tumor. Patient had a glioma in the dorsal midbrain, did not survive. So now we come to the main part, that is the infantile nystagmus syndrome, often characterized by a head posture. Patients may have a null zone. It is accentuated by fixation. So if you don't give the patient a fixation target, you may actually miss the nystagmus. Okay, so this video is primarily to tell you the importance of recording a binocular visual acuity. This is a patient with a latent nystagmus. Okay, so as soon as you cover one eye, the direction of nystagmus is towards the fixing eye, and if you try to test monocular visual acuity, it will almost always be less. So you have to check for visual acuity by fogging, or you have to check the binocular visual acuity. So for infantile nystagmus syndrome, for vantage of time, I will just move on to the principle of surgery. We aim to move the null zone. The principle is you move the eyes towards the direction of the head posture and attempt to broaden the null zone. As Laila madam had already said, periodic alternating nystagmus is something to watch for. So you need to have 2 observation periods of at least 8 minutes each. That is the minimum, and the head posture should be the same. This is the minimum that you need to do. And this was a patient with an infantile nystagmus syndrome. So many of them come in adulthood, especially around marriage time. So if you notice, when the patient adopts the head posture, so there's hardly any nystagmus. And now when you forcibly correct the head posture and give the patient a distance fixation target, that is very important. Unless you do that, you won't pick up the magnitude of the nystagmus. So when you do that, so this is after surgery. Okay, I will come to what surgery. There are so many techniques, but all of them are based on the same principle: move the eyes symmetrically in the direction of the head posture. So this is after surgery. So what we did was a plication augmentation of the augmented Anderson procedure. So augmented Anderson procedure was popularized by my mentor Sharma sir, and it essentially is 12 millimeter recession of lateral on one side and 9 millimeter on the other side. For larger head posture, you can add a plication. So the advantage of the augmented Anderson is if you do miss a periodic alternating nystagmus, what you can do is you can go and recess the other two recti. In plication augmentation, you can go and cut the plication suture and proceed with recession. So plication augmentation preserves the reversibility of the augmented Anderson procedure. And so these are very important things. You need to check for the forced best corrected visual acuity. That is 2 lines below whatever visual acuity the optometrist has recorded. I'll just sum up in 2 slides. So unless you do this, the patient won't adopt the maximum head posture. So even if you do small amounts of surgery, you may feel that the surgical effect has come. Whereas in reality, if you force the patient to adopt a head posture, because by reading 2 lines below their visual acuity, then you will bring out the maximum head posture. And of course, the reversal of fast phase and prisms to just reverse the posture. I will show this video and I will wrap up. So this was a patient with a verticalness, with a vertical head posture, chin up. So when you correct the head posture, you notice that the nystagmus has a large amplitude. And for near the head posture usually is less. So you base your surgery and surgical planning based on the distance head posture. So this is what I said. So you neutralize with prisms, apex towards the gaze or base towards the head posture in such a way that the head posture is slightly reversed. So that should be your target angle. And we did bilateral inferior rectus recession with a slight nasal shifting and superior rectus plication, and that was the head posture pre-op. And this is so. If you have a complex head posture in many planes, note for the go for the primary, the chief head posture, which is the horizontal in this case. And these are other patients. So this is my last video. So very difficult case, exotropia with face turn towards the fixing eye. So that is the hardest face turn to correct. So if you notice, so I have prevented the patient from adopting a head posture. This was the head posture. So as soon as you cover one eye, the face turn shifts to the fixing eye. So this is by asking the patient to read 2 lines below. And what we did here was a bilateral large lateral rectus recession with a medial rectus farden. So this was the result, and thank you so much. Thank you.
Thank you, sir, for that enlightening talk. But for want of time, we would have had more. Thank you.